So we are starting this session with acute odontogenic infections, page number 79 from therapeutic guidelines. Acute odontogenic tooth-related infections are common and can affect dental pulp secondary to the restoration breakdown, dental caries or loss of tooth structure from trauma. One source of infection is acute odontogenic infection. The second is periodontal tissues, most commonly due to advanced periodontitis. The third is pericoronal tissues, most commonly from partially erupted mandibular third molars. If an odontogenic infection is ignored or not appropriately treated, it can progress to a localized abscess or spread to soft tissues of the face or neck. So there is a difference between localized abscess and soft tissue spread of face or neck. But rare but serious complications include Ludwig angina, airway compromise, sepsis, or spread to the bone, brain, neck, or mediastinum. Immunocompromised patients are prone to rapidly spreading infection. Persistent dental pain and swelling after dentoalveolar surgery could be due to alveolar osteitis, which is dry socket, or a post-operative infection. Osteomyelitis of the jaw is an important differential diagnosis in patients with an unresolved oral infection. So they can have, if it proceeds further, the post-operative infection or alveolar osteitis, it can, unresolved oral infection can deepen into the bone and create osteomyelitis, and it will have systemic features and localized bone pain or tenderness. If osteomyelitis of the jaw is suspected, refer the patient to the hospital and expert advice would be needed. So long-standing bone infections, even periapical or any kind of infections can cause the whole bone to get infected. Differential diagnoses include osteonecrosis here, which can be medication-related osteonecrosis of the jaw, or osteoradionecrosis, which happens in patients undergoing radiation therapy. But whatever it is, differential diagnosis for both is necrosis of the bone. Then approach of managing acute odontogenic infections. Now, this topic is very important. You can always expect questions on acute odontogenic infection in ADC. Acute odontogenic infection requires prompt management with dental treatment. Dental treatment is the prime line and not the antibiotics. Extraction, root canal, or surgical intervention to address the source of infection. That is the first key highlighting point. Antibiotic therapy is not a substitute for dental treatment, but may be required if dental treatment is not likely to be received within 24 hours. So if you can initiate root canal treatment or do our extraction when the patient reports to you, please proceed, and this patient does not need antibiotics. Whether the patient can be managed in community or requires hospital admission depends on severity of the infection. Next, we would need to seek the expert advice for the patients with recurrent infection who have received antibiotics but not dental treatment. So if a patient comes to you who has already been referred by, say, a medical practitioner, that he has already completed a course of antibiotics, but swelling has still not gone. So expert advice is needed in them. Again, they have highlighted this: antibiotic therapy is not a substitute for dental treatment of odontogenic infection. Odontogenic infection is usually polymicrobial, involving anaerobic and aerobic oral bacteria. Metronidazole is used in conjunction with the penicillin because of increased rates of resistance to penicillins in some oral bacteria, example Prevotella oralis. However, amoxicillin plus clavulinate has adequate anaerobic activity, so can be used as single preparation. Either we can use metro and penicillin, or we can use amoxiclavulinate. So we have features and overview of management of acute odontogenic infections. Localized odontogenic infection would present as dental pain, abscess or localized swelling on the gum or a fluctuant tissue. Pus may be visible. There will not be a facial swelling. No severe or systemic features of infection. Management overview would be outpatient dental department. If dental treatment is not likely to be received within 24 hours, medical practitioners can start antibiotic therapy. However, ensure the patient receives dental treatment. So within 24 hours, no need to start the medicine therapy, antibiotic therapy. And only if after presentation, still 24 hours are there for reporting to dentist, or we cannot start treatment today. Maybe the patient is having diabetes. The patient, we don't know the status of the diabetes control. Patient says he has not had breakfast. It's already the time of clinic closure. So then we prescribe antibiotic and ask the patient to return tomorrow for dental extraction or RCT starting, whatever it is. This was localized odontogenic infection. Then we have a spreading odontogenic infection without severe or systemic features. In this, the patient would have facial swelling, dental and facial pain. There will be an abscess on the gum or a fluctuant tissue. Pus may be visible. No severe or systemic features of infection. So here it was dental pain only. In localized odontogenic infection, there was no facial swelling per se. But when it is spreading, there is a facial swelling. It's an important difference. Outpatient dental treatment followed by oral antibiotic therapy. So here we can do the dental treatment in OPD, plus we have to give here oral antibiotics. If dental treatment is not likely to be received within 24 hours, medical practitioners can start antibiotic therapy. However, ensure that the patient receives dental treatment. By meaning of ensuring that patient receives dental treatment, it means contact the patient, contact the person you have done the referral, whether the patient has approached there and got the extraction done or root canal access opening done. Spreading odontogenic infection with severe or systemic features. Now, severe features such as significant facial swelling and pain, trismus, neck swelling, difficulty swallowing, difficulty breathing, or airway compromise. Systemic features such as pallor, sweating, tachycardia, and axillary temperature above 38 degrees Celsius or sepsis. This all must be done for the patients. Must be the features presenting with spreading odontogenic infection with severe or systemic features. So severe or systemic features means there will be sweating, tachycardia, axillary temperature above 38 degrees Celsius. Fever is one sign of systemic involvement. We always check fever in spreading odontogenic infections. In fact, how do we know this infection was spreading or not spreading? By checking the temperature. The action you will do to check systemic involvement or not is pallor, sweating, tachycardia. If they visibly happen, it's very well evident, then fine. Otherwise, we would have to note the temperature. Then provide appropriate support of airway, breathing, and circulation in these patients. And here it is very important, there is urgent transfer to a hospital with oral and maxillofacial surgeon or other appropriate expert. Surgical intervention and intravenous antibiotic therapy should be used. Oral temperatures are unreliable for infections originating in the mouth. So thermometer checking in the oral cavity is unreliable. We have to see the axillary temperature. Then we have odontogenic localized infections. We'll quickly go through this figure again. Odontogenic infection is considered to be localized if it causes dental pain without facial swelling or systemic features. Localized odontogenic infections can involve any of these areas: periapical, pericoronal, periodontal abscesses for anatomical location. Signs of abscess include visible pus, a localized swelling on the gum, or fluctuant tissue. However, dental pain may be the only sign in case of a periapical abscess. So, periapical abscess, only dental pain, and pus, visible, localized swelling, or gum in the periodontal abscess or a pericoronal abscess. We have read this picture: pericoronitis, pericoronal abscess, gingivitis, periodontitis, periodontal abscess. Number 5, this is the gingivitis, this is periapical abscess. The key to successful management of localized odontogenic infection is dental treatment to drain pus and address the source of infection. For treatment options, which are given in the next page, antibiotic therapy is not required because dental treatment removes the source of infection and bacteremia caused by treatment resolves rapidly. Do not routinely give antibiotic therapy after dental treatment for a localized odontogenic infection. However, what happens if an infected tooth breaks during an extraction? You were doing an extraction and tooth broke, and it was an infected tooth. There is a delay in removing the residual root or bone fragments. The specialist is not available. You need to refer the patient to the oral surgeon. Antibiotic therapy is indicated in. If the tooth is not infected, antibiotic therapy is not required. So very clear-cut demarcation they have done. If you were removing, say, 1/6 and the palatal root was already infected, you could not retrieve the palatal root. You have to make a referral to the oral surgeon. It is taking some time. It is not happening then and there in the same open wound. So you would prescribe antibiotic. If the root was not having any periapical radiolucency, it is clear of any periapical abscess per se, then it is not an infected tooth, then you would be referring to the specialist for root removal, but this time you are not prescribing antibiotic. Patients with localized odontogenic infection may present to a medical practitioner, promptly refer the patient to a dentist for treatment. And again, medical practitioners will see if the treatment is not likely to be received within 24 hours, start antibiotic. For an appropriate regimen, we would follow the regimen of amoxicillin. However, antibiotic therapy is not a substitute for the dental treatment, so ensure the patient sees the dentist. Offer systemic analgesics for the treatment of the dental pain. For pericoronal infections, irrigate the area with sterile saline solution. Recommend rinsing with warm saline or chlorhexidine mouthwash until dental treatment can take place. Then we have dental treatment options for acute localized odontogenic infections. We have periapical abscess, endodontic root canal treatment, tooth extraction. Then we have periodontal abscess, periodontal treatment debridement, and tooth extraction are the treatment modalities. Then we have pericoronal infection, again tooth extraction, or remove or recontour the opposing tooth, because that was the tooth giving friction or trauma. Then we have spreading odontogenic infections without severe or systemic features. A spreading infection that has caused facial swelling but no severe or systemic features can be managed in an outpatient dental setting. Management involves drainage of the pus with culture and susceptibility testing of the pus sample. So it was a swelling, it was area on the face or maybe in the mandible chin area. So drain the pus and do the culture and susceptibility testing. Surgical or dental treatment would be needed, which is endodontic or periodontal treatment to address the source of infection. So which tooth is infected, we have to remove it. Oral antibiotic therapy ideally started after samples taken are taken for the culture. It may be not possible to achieve adequate analgesia with LA in patients with spreading odontogenic infection. So there is a swelling, there is pus accumulation. LA may not work. However, this should not delay the treatment. Anxiolysis, minimal sedation, or general anesthesia may be required. Once the source of infection has been addressed, start the antibiotic therapy. So you have to address the source of infection. A culprit tooth has to be addressed first. Patients with spreading odontogenic infection may report to a medical practitioner because they have a swelling. They may directly go there. Then medical practitioner needs to refer the patient to the dentist for prompt treatment. If dental treatment is not likely to be received within 24 hours, start antibiotic therapy. And however, antibiotic therapy is not a substitute to dental treatment, so ensure patient sees the dentist. Offer systemic analgesics also for pain relief. So what is the antibiotic therapy for spreading odontogenic infections without systemic involvement or severe features? It is metronidazole 400 milligram. In child, it is 10 milligram per kg up to 400 milligram orally, 12 hourly for 5 days, plus either phenoxymethylpenicillin 500 milligram, 12.5 milligram per kg to 500 milligram orally, 6 hourly for 5 days. Or amoxicillin 500 milligram, child 15 milligram per kg up to 500 milligram orally, 8 hourly for 5 days. So this is metronidazole plus either phenoxymethylpenicillin or amoxicillin. Remember the dosages, the same medications actually they keep repeating every time. So metronidazole, the dosage will not change. It would remain same for wherever it is coming in use. Or as a single preparation, we can use amoxiclavulinate, 875 plus 125 milligram, and 12 hourly for 5 days. For patients who are hypersensitive to penicillins, we can give clindamycin 300 milligram orally, 8 hourly for 5 days. Very important, if cannot give amoxicillin, penicillin group of drugs, clindamycin 300 milligram is the choice. Review the patient in 48 to 72 hours after starting the treatment to check the response. Advise the patient to seek prompt dental review if their condition deteriorates or if the infection has not resolved within 5 days. So 48 to 72 hours review is very important. If the infection has not responded to the treatment, ensure source of infection has been addressed. Pus was drained adequately. CT can be done to check locules requiring the drainage. The infection is susceptible to current antibiotic regimen. If the results of the culture and susceptibility testing are available, modify antibiotic therapy accordingly. Failing this, or if the patient's condition has deteriorated, seek expert advice from oral and maxillofacial surgeon. Transfer to inpatient facility may be required. So the patient may require hospital admission. The last part is spreading odontogenic infections with severe or systemic features, which may be Ludwig's angina also. So severe features of spreading infection include significant facial swelling and pain, trismus, swelling of the neck, difficulty swallowing, difficulty breathing. So the patient is going into extremes of infection where swelling, pain, trismus, patient is not able to open the mouth completely. There is a neck swelling, swallowing, difficulty breathing. Systemic features include pallor, sweating, tachycardia, axillary temperature above 38 degrees Celsius. Infection can rapidly become life-threatening because the risk of airway obstruction. So very important, it's a life-threatening infection if it is spreading with systemic features. Ludwig in China is severe spreading infection involving bilateral submandibular and sublingual and submental spaces with cellulitis. Cellulitis means it's cutting the facial fascia within and spreading. Okay. Arrange an urgent transfer of the patient who have spreading infection with severe or systemic features to a hospital that has an oral and maxillofacial surgeon. You are reiterating urgency of the situation and referring the patient to the hospital. Management of the patient with spreading or severe systemic features involves maintaining the patent airway. Do not lie the patient flat. Resuscitation, draining the pus by incising affected spaces and placing the drains. Removing the tooth, otherwise addressing the source of infection. So here drainage is established first and then removal of the tooth is done. Obtain blood and other samples of culture and susceptibility testing. Intravenous antibiotic therapy is done. So here intravenous IV therapies, antibiotics are given. In the previous case where it was not systemic features, there oral antibiotics were given. Now, spreading odontogenic infections can be associated with sepsis. And sepsis means the whole of the organ, the full body gets into the sepsis and can even result into a shock, septic shock, which we say. For patients with sepsis, start antibiotic therapy within 1 hour of presentation to the medical care. Antibiotics should be given immediately after appropriate samples are taken. Obtain blood samples and other relevant samples as soon as possible, but not if doing so will delay the antibiotic administration. For antibiotic management of sepsis, we would see the other area of ETG. Empirical antibiotic in this severe or systemic features, including Ludwig in China, in conjunction with surgical intervention. What we would use, benzyl penicillin intravenously. Patients requiring intensive care support 2.4 gram 4 hourly. And patients not requiring intensive care support 1.8 gram 4 hourly. So here benzyl penicillin every 4 hourly we need to give, which require ICU 2.4 gram, not requiring means okay, can be a bit stable, it is 1.8. Plus metronidazole, which is here it is 500 milligram, here it is intravenously 12 hourly. Both are intravenous. Or as a single preparation, what you can give is amoxiclavulinate intravenously here. So here all the medicines are going intravenously. For patients with immediate non-severe or delayed non-severe hypersensitivity to penicillins, cefazolin 2 gram. It's intravenously 8 hourly. For adults requiring intensive care support, use 6 hourly dosing. Plus metronidazole 500 milligram intravenously 12 hourly. So this is non-severe delayed hypersensitivity to penicillins. We are using cefazolin and metro combination. And immediate severe or delayed hypersensitivity, you are using clindamycin 600 milligram IV 8 hourly or lincomycin 600 milligram IV 8 hourly. Do stick some tables, make colorful charts and try to memorize this medications very thoroughly. Modify therapy based on the results of the cultures. We need to, as mentioned, as written in the previous chapters, after culture sensitivity results come, switch to oral therapy once swelling and trismus have subsided and the patient can swallow. And purulent discharge from the drains slow. If the results of susceptibility testing are not available for oral continuation therapy, use the appropriate regimen as prescribed. Stop oral antibiotic therapy once the drains are not producing any purulent discharge, signs and symptoms have resolved, the white cell count has returned to normal, and the patient is afebrile. Then we have, they have mentioned that at the time of writing, there is limited clinical evidence to determine optimal dosage regimen for IV amox and clavulanate for adults with spreading odontogenic infection with severe or systemic features. Reasonable alternative regimen is 2 plus 0.2 gram intravenously for amox clav. And if the abscess is adequately drained, amoxicillin dosage can be reduced 1 plus 0.2. And again, the same thing is repeated for the children who weigh above 40 kg also. Then the last in the series is infection following dentoalveolar surgery. So this is an infection which happens after tooth extraction, implant placement, or associated procedures. It's uncommon and its incidence is not reduced by surgical antibiotic prophylaxis. So if we have done a tooth extraction, there is no point giving any antibiotic because infection is not a very common occurrence, but it can still happen. Before diagnosing post-operative dental infection, we should exclude post-surgical inflammation and alveolar osteitis, which is dry socket. Signs and symptoms of infection are cellulitis adjacent to the surgical site, fluctuant surgical site, purulent discharge from the surgical site, pain and swelling that is worsening or not improving 48 hours after the surgery. If post-operative dental infection is associated with severe symptoms like significant facial swelling and pain, trismus, swelling of the neck, difficulty swallowing, difficulty breathing, follow the management advice as previously given. Management of the post-operative dental infection not associated with severe symptoms requires draining pus, addressing the source of infection, including removing residual root or tooth fragments if demonstrated on X-ray, analgesia, and rehydration therapy. Most post-operative dental infections can be managed by dental treatment alone. However, if patient is immunocompromised or has systemic features of infection, which are well mentioned previously also, pallor, sweating, tachycardia, axillary temperature above 38 degrees Celsius, consider using antibiotic therapy in addition to dental treatment. If antibiotic therapy is indicated, regimens for spreading one odontogenic infections should be appropriate. Again, review the patients for 48 to 72 hours after starting treatment to check response. Advise patients to seek prompt dental review if the condition deteriorates or if the infection has not resolved within 5 days. This completes the types of odontogenic infections that can happen in the oral cavity. And in these, all the cases, we have to make tables and try to memorize what is to be done and not to be done. Suppose it's a spreading odontogenic infection without severe systemic features. So here, oral drugs are sufficient. The source of infection must be removed, plus oral drugs are given. Whereas if they change the word to patient is unable to breathe, patient is sweating, patient is having a difficulty opening the mouth. So all this will suggest systemic features involvement, and your first line of thing will be to send this patient, refer this patient to oral and maxillofacial surgeon in the hospital. Urgent transfer is our key. And there, memorizing the dosages is less important because it's the IV, whatever treatment is happening in the hospital. However, we are still learning the values for exam point of view, though it is less likely to be asked in comparison to what you are directly prescribing. And that was it about this infections, and we would proceed with the subsequent chapter in the next session, which is salivary gland infections. All right.